This talk is about management of graft astigmatism, covering penetrating keratoplasty and deep anterior lamellar keratoplasty. What is your strategy? I'm joined by Professor Bert Jun from the Wilmer Eye Institute. So I'll be proposing a series of multiple choice questions related to penetrating keratoplasty and DALK. And it's just about what you might do in your usual practice. And we all know that individual cases demand different techniques. Looking at intra-operative factors. Question 1. So how much do you oversize your graft versus the host? So is it 1 the same, 2 0.25 millimeters, 3 half a millimeter, 4 3/4 millimeter, 5 1 millimeter, 6 depends on the condition, or any other suggestions?
Well, I will oversize the graft depending on the condition, and basically the way I will do it is for keratoconus patients, they are oversized by a quarter, 0.25 millimeters. For patients who are either phakic or pseudophakic with intact zonules, I will oversize by a half millimeter, and for aphakic patients or patients without intact zonules, I will oversize by 3/4 of a millimeter.
All right. So what's your rationale behind those different measurements?
Well, I think that the idea with the cone patients is that they generally have an expanded anterior chamber. They have a steep cornea with myopia, and I think the idea of flattening the cornea afterwards, not excessively, but to a more normal range, gives a better spherical refractive outcome. With half millimeter, I think that's just more of kind of an empiric approach. Obviously you want to maintain a reasonable AC depth and a reasonable corneal curvature, and I think that half a millimeter there tends to give a reasonable outcome. And then I think that sort of the basis for the aphakes or patients without intact zonules, I think there is something about how the front of the eye relaxes when the cornea is incised, and I do think that the zonules provide some sort of structural support to the cornea and to the angle, and so I think that I'm just kind of holding everything together, if you will, so that when you cut the cornea and sort of violate the integrity of the eye wall, I think the front of the eye tends to just relax just a little bit more. And this kind of came out from some early experience going way back after I recently finished my fellowship in some of these aphakes that I did PKs on, and they ended up with very flat corneas, and I felt like they needed a little bit more tissue just to kind of allow the cornea to protrude forward a little bit and give a little bit more curvature.
If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.